Comprehensive Person-Centered Care Planning. Appendix PP, Regulation Section 483.21, tags F655 through F661. Begin reading. Tag F655. Section 483.21, Comprehensive Person-Centered Care Planning. Section 483.2, 1A Baseline Care Plans. Section 483.21A1, the facility must develop and implement a baseline care plan for each resident that includes the instructions needed to provide effective and person-centered care of the resident that meet professional standards of quality care. The baseline care plan must be developed within 48 hours of a resident's admission. Roman 2, include the minimum healthcare information necessary to properly care for a resident, including, but not limited to: A. Initial goals based on admission orders. B. Physician orders. C. Dietary orders. D. Therapy services. E. Social services. F. PASAR recommendation, if applicable. Section 483.21A2, the facility may develop a comprehensive care plan in place of the baseline care plan if the comprehensive care plan is developed within 48 hours of the resident's admission. Roman 2 meets the requirements set forth in paragraph B of this section, excepting paragraph B2I of this section. Section 483.21A3, the facility must provide the resident and their representative with a summary of the baseline care plan that includes, but is not limited to: the initial goals of the resident. Roman 2, a summary of the resident's medications and dietary instructions. Roman 3, any services and treatments to be administered by the facility and personnel acting on behalf of the facility. Roman 4, any updated information based on the details of the comprehensive care plan, as necessary. Intent Section 483.21A. Completion and implementation of the baseline care plan within 48 hours of a residence. Admission is intended to promote continuity of care and communication among nursing home staff, increase resident safety, and safeguard against adverse events that are most likely to occur right after admission, and to ensure the resident and representative, if applicable, are informed of the initial plan for delivery of care and services by receiving a written summary of the baseline care plan. Guidance Section 483.21A. Nursing homes are required to develop a baseline care plan within the first 48 hours of admission, which provides instructions for the provision of effective and person-centered care to each resident. This means that the baseline care plan should strike a balance between conditions and risks affecting the resident's health and safety, and what is important to him or her within the limitations of the baseline care plan timeframe. Person-centered care means the facility focuses on the resident as the center of control and supports each resident in making his or her own choices. Person-centered care includes making an effort to understand what each resident is communicating, verbally and non-verbally, identifying what is important to each resident with regard to daily routines and preferred activities, and having an understanding of the resident's life before coming to reside in the nursing home. The baseline care plan must include the minimum healthcare information necessary to properly care for each resident immediately upon their admission, which would address resident-specific health and safety concerns to prevent decline or injury, such as elopement or fall risk, and would identify needs for supervision, behavioral interventions, and assistance with activities of daily living as necessary. Baseline care plans are required to address, at a minimum, the following: initial goals based on admission orders, physician orders, dietary orders, therapy services, social services. Pass our recommendation, if applicable. The baseline care plan must reflect the resident's stated goals and objectives and include interventions that address his or her current needs. It must be based on the admission orders. Information about the resident available from the transferring provider and discussion with the resident and resident representative, if applicable, because the baseline care plan documents the interim approaches for meeting the resident's immediate needs, professional standards of quality. Care would dictate that it must also reflect changes to approaches, as necessary, resulting from significant changes in condition or needs occurring prior to development of the comprehensive care plan. Facility staff must implement the interventions to assist the resident to achieve care. Plan goals and objectives. Facilities may complete a comprehensive care plan instead of the baseline care plan. In this circumstance, the completion of the comprehensive care plan will not override the RAI process and must be completed and implemented within 48 hours of admission and comply with the requirements for a comprehensive care plan at Section 483.21b, with the exception of the requirement at B2I requiring the completion of the comprehensive care plan within 7 days of completion of the comprehensive assessment, if a comprehensive care plan is completed in lieu of the baseline care plan. A written summary of the comprehensive care plan must be provided to the resident and resident representative, if applicable, and in a language that the resident/representative can understand. If the facility completes a comprehensive care plan instead of the baseline care plan, review the requirements of the comprehensive care plan at Section 483.21b. If the care plan does not meet the requirements of Section 483.21b, cite at the appropriate corresponding tag S. F656, develop comprehensive care plan. F657, care plan timing and revision. F658, services provided meet professional standards. F659, qualified persons. Baseline care plan summary. The facility must provide the resident and the representative, if applicable, with a written summary of the baseline care plan by completion of the comprehensive care plan. The summary must be in a language and conveyed in a manner the resident and/or representative can understand. This summary must include initial goals for the resident, a list of current medications and dietary instructions, and services and treatments to be administered by the facility and personnel acting on behalf of the facility. The format and location of the summary is at the facility's discretion. However, the medical record must contain evidence that the summary was given to the resident and resident representative, if applicable. The facility may choose to provide a copy of the baseline care plan itself as the summary, as long as it meets all of the requirements of the summary. Given that the baseline care plan is developed before the comprehensive assessment, it is possible that the goals and interventions may change. In the event that the comprehensive assessment and comprehensive care plan identified a change in the resident's goals or physical, mental, or psychosocial functioning, which was otherwise not identified in the baseline care plan, those changes must be incorporated into an updated summary provided to the resident and his or her representative, if applicable. As the resident remains in the nursing home, additional changes will be made to the comprehensive care plan based on the assessed needs of the resident. However, these subsequent changes will not need to be reflected in the summary of the baseline care plan. Once the comprehensive care plan has been developed and implemented, and a summary of the updates given to the resident, the facility is no longer required to revise/update the written summary of the baseline care plan. Rather, each resident will remain actively engaged in his or her care planning process through the resident's rights to participate in the development of and be informed in advance of changes to the care plan, see the care plan, and sign the care plan after. Significant changes. Refer to Section 483.10C for guidance related to resident rights and facility responsibilities regarding planning and implementing care. Investigative Summary and Probes Section 483.21A. Use the critical element C pathway associated with the issue under investigation, or if there is no specific CE pathway, use the general CE pathway, along with the above. Interpretive guidelines when determining if the facility meets the requirements for, or investigating concerns related to the facility's requirement develop and implement a baseline care plan. If systemic concerns are identified with baseline care plans, use the probes below to assist in your investigation. Was the baseline care plan developed and implemented within 48 hours of admission to the facility? Does the resident's baseline care plan include the resident's initial goals for care? The instructions needed to provide effective and person-centered care that meets professional standards of quality care. The resident's immediate health and safety needs. Physician and dietary orders. Pass our recommendations, if applicable, and therapy and social services. Was the baseline care plan revised and updated as needed to meet the resident's needs until the comprehensive care plan was developed? If the resident experienced an injury or adverse event prior to the development of the comprehensive care plan, should the baseline care plan have identified the risk for the injury/event, i.e., if risk factors were known or obvious? Did the facility provide the resident and his or her representative, if applicable, with a written summary of the baseline care plan that contained at least, without limitation, initial goals of the resident, a summary of current medications and dietary instructions, services and treatments to be provided or arranged by the facility and personnel acting on behalf of the facility, and any updated information based on details of the admission comprehensive assessment. Tag F656. Section 483.21b, Comprehensive Care Plans. Section 483.21b1, the facility must develop and implement a comprehensive person-centered care plan for each resident, consistent with the resident rights set forth at Section 483.10C2 and Section 483.10C3. That includes measurable objectives and timeframes to meet a resident's medical, nursing, and mental and psychosocial needs that are identified in the comprehensive assessment. The comprehensive care plan must describe the following: the services that are to be furnished to attain or maintain the resident's highest practicable physical, mental, and psychosocial well-being, as required under Section 483.24, Section 483.25, or Section 483.40, and Roman II, any services that would otherwise be required under Section 483.24, Section 483.25, or Section 483.40, but are not provided due to the resident's exercise of rights under Section 483.10, including the right to refuse treatment under Section 483.10C6. Roman III, any specialized services or specialized rehabilitative services the nursing facility will provide as a result of PASAR recommendations. If a facility disagrees with the findings of the PASAR, it must indicate its rationale in the resident's medical record. Roman IV, consultation with the resident and the resident's representative S. A. The resident's goals for admission and desired outcomes. B. The resident's preference and potential for future discharge. Facilities must document whether the resident's desire to return to the community was assessed, and any referrals to local contact agencies and / or other appropriate entities. For this purpose, see discharge plans in the Comprehensive Care Plan as appropriate in accordance with the requirements set forth in paragraph C of this section. Section 483.2, 1B3 The services provided or arranged by the facility, as outlined by the Comprehensive Care Plan, must Roman 3 be culturally competent and trauma-informed. Intent. Each resident will have a person-centered comprehensive care plan developed and implemented to meet his or her preferences and goals and address the resident's medical, physical, mental, and psychosocial needs. Definitions. Culture is the conceptual system that structures the way people view the world. It is the particular set of beliefs, norms, and values that influence ideas about the nature of relationships, the way people live their lives, and the way people organize their world. Adopted from Substance Abuse and Mental Health Services Administration, Improving Cultural Competence. Treatment Improvement Protocol Tip Series No. 59. HHS Publication No. SMA 14 to 4849. https://storesamsagov/systems/files/SMA 14 to 4849. PDF. Cultural competency is a developmental process in which individuals or institutions achieve increasing levels of awareness, knowledge, and skills along a cultural competence continuum. Cultural competence involves valuing diversity, conducting self-assessments, avoiding stereotypes, managing the dynamics of difference, acquiring and institutionalizing cultural knowledge, and adapting to diversity and cultural contexts in communities. U.S. Department of Health and Human Services publication, A Blueprint for Advancing and Sustaining Clause Policy and Practice at https://www.thinkculturalhealthhhs.gov/clause/blueprint. Resident's goal refers to the resident's desired outcomes and preferences for admission, which guide decision-making during care planning. Interventions are actions, treatments, procedures, or activities designed to meet an objective. Measurable is the ability to be evaluated or quantified. Objective is a statement describing the results to be achieved to meet the resident's goals. Person-centered care means to focus on the resident as the locus of control and support the resident in making their own choices and having control over their daily lives. Trauma-informed care is an approach to delivering care that involves understanding, recognizing, and responding to the effects of all types of trauma. A trauma-informed approach to care delivery recognizes the widespread impact and signs and symptoms of trauma in residents, and incorporates knowledge about trauma into care plans, policies, procedures, and practices to avoid re-traumatization. Adapted from SAMHSA Concept of Trauma and Guidance for a Trauma-Informed Approach, https://storesamsagov/systems/files/SMA 14 to 4884. PDF. Guidance. Through the care planning process, facility staff must work with the resident and his or her representative, if applicable, to understand and meet the resident's preferences, choices, and goals. During their stay at the facility must establish, document, and implement the care and services to be provided to each resident to assist in attaining or maintaining his or her highest practicable quality of life. Care planning drives the type of care and services that a resident receives. If care planning is not complete or is inadequate, the consequences may negatively impact the resident's quality of life as well as the quality of care and services received. Facilities are required to develop care plans that describe the resident's medical, nursing, physical, mental, and psychosocial needs and preferences, and how the facility will assist in meeting these needs and preferences. Care plans must include person-specific, measurable objectives and timeframes in order to evaluate the resident's progress toward his or her goals. Care plans must be person-centered and reflect the resident's goals for admission and desired outcomes. Person-centered care means the facility focuses on the resident as the center of control and supports each resident in making his or her own choices. Person-centered care includes making an effort to understand what each resident is communicating, verbally and non-verbally, identifying what is important to each resident with regard to daily routines and preferred activities, and having an understanding of the resident's life before coming to reside in the nursing home. Residents' goals set the expectations for the care and services he or she wishes to receive. For example, a resident admitted for rehabilitation may have the following goal: receive the necessary care and services so that I may return to independent living. Another resident may have a goal of receiving the necessary care and services to meet needs they cannot independently achieve while maintaining as much independence as possible, and yet another resident or his or her representative, if applicable, may have a goal of receiving the necessary care and services to keep the resident comfortable and pain-free at the end of their life. Each of these examples would be supported by measurable objectives, interventions, and timeframes designed to meet each specific resident goal. Measurable objectives describe the steps toward achieving the resident's goals and can be measured, quantified, and or verified. For example, Mrs. Jones, who underwent hip replacement, will report adequate pain control as evidenced by pain at 1 to 3, on a scale of 1 to 10. Throughout her SNF stay, facility staff will use this objective to monitor the resident's progress. The comprehensive care plan must reflect interventions to enable each resident to meet his or her objectives. Interventions are the specific care and services that will be implemented. Interventions for the example above, related to pain, may include, but are not limited to: evaluate pain level using pain scale 0 to 10 45 minutes after administering pain. Medication. Administer pain medication 45 to 60 minutes prior to physical therapy. When developing the comprehensive care plan, facility staff must, at a minimum, use the minimum data set MDS to assess the resident's clinical condition, cognitive and functional status, and use of services. If a care area assessment CAA is triggered, the facility must further assess the resident to determine whether the resident is at risk of developing or currently has a weakness or need associated with that CAA, and how the risk, weakness, or need affects the resident. Documentation regarding these assessments and the facility's rationale for deciding whether or not to proceed with care planning for each area triggered must be recorded in the medical record. There may be times when a resident risk, weakness, or need is identified within the context of the MDS assessment but may not cause a CAA to trigger. The facility is responsible for addressing these areas and must document the assessment of these risks, weaknesses, or needs in the medical record and determine whether or not to develop a care plan and interventions to address the area. If the decision to proceed to care planning is made, the interdisciplinary team IT, in conjunction with the resident and or resident's representative, if applicable Section 483.2 1B2 Roman 2, must develop and implement the comprehensive care plan and describe how the facility will address the resident's goals, preferences, strengths, weaknesses, and needs. Note, although federal requirements dictate the completion of RAI assessments, according to certain time frames. Standards of good clinical practice dictate that the clinical assessment process is more fluid and should be ongoing. The lack of ongoing clinical assessment and identification of changes in condition to meet the resident's needs between required RAI assessments should be addressed at Section 483.35 Nursing Services, F626 Competency and Skills to identify and address a change in condition, and the relevant outcome tag, such as Section 483.12. Abuse, Section 483.24, Quality of Life, Section 483.25, Quality of Care, and / or Section 483.40, Behavioral Health. In some cases, a resident may wish to refuse certain services or treatments that professional staff believes may be indicated to assist the resident in reaching his or her highest practicable level of well-being or to keep the resident safe. In situations where a resident's choice to decline care or treatment, e.g., due to preferences, maintain autonomy, etc., poses a risk to the resident's health or safety, the comprehensive care plan must identify the care or service being declined, the risk the declination poses to the resident, and efforts by the interdisciplinary team to educate the resident and the representative, as appropriate, the facility's attempts to find alternative means to address the identified risk/need should be documented in the care plan. See guidelines at Section 483.10 C6F 578 for additional guidance concerning the resident's decision to refuse treatment. Additionally, a resident's decision-making ability may decline over time. The facility should determine how the resident's decisions may increase risks to health and safety, evaluate the resident's decision-making capacity, and involve the interdisciplinary team and the resident's representative, if applicable, in the care planning process. In addition to addressing preferences and needs assessed by the MDS, the comprehensive care plan must coordinate with and address any specialized services or specialized rehabilitation services the facility will provide or arrange as a result of PASAR recommendations. If the IDT disagrees with the findings of the PASAR, it must indicate its rationale in the resident's medical record. The rationale should include an explanation of why the resident's current assessed needs are inconsistent with the PASAR recommendations and how the resident would benefit from alternative interventions. The facility should also document a resident's preference for a different approach to achieve goals or refusal of recommended services. Residents' preferences and goals may change throughout their stay, so facilities should have ongoing discussions with the resident and resident representative, if applicable, so that changes can be reflected in the comprehensive care plan. The comprehensive care plan must address a resident's preference for future discharge as early as upon admission to ensure that each resident is given every opportunity to attain his or her highest quality of life. This encourages facilities to operate in a person-centered fashion that addresses resident choice and preferences. Culturally competent care. Cultural competency, also known as cultural responsiveness, cultural awareness, and cultural sensitivity, refers to a person's ability to interact effectively with persons of cultures different from his or her own. It means being respectful and responsive to the health beliefs, practices, and cultural and linguistic needs of diverse population groups, such as racial, ethnic, religious, or social groups. https://www.samhisagov/capt/applying strategic prevention/cultural competence. The interventions in the resident's care plan must reflect the individual resident's needs and preferences and align with the resident's cultural identity. Trauma-informed care. Given the widespread nature and highly individualized experience of trauma, the utilization of trauma-informed approaches is an essential part of person-centered care. Facilities must recognize the effects of past trauma on residents and collaborate with the resident, family, and friends of the resident to identify and implement individualized interventions. Interventions for trauma survivors should recognize the interrelation between trauma and symptoms of trauma, such as substance abuse, eating disorders, aggression, depression, anxiety, and withdrawal, or isolation from others. Surveyors should refer to the following when investigating concerns related to culturally competent, trauma-informed care. F656, for concerns related to development or implementation of culturally competent and / or trauma-informed care plan interventions. F699, for concerns related to outcomes or potential outcomes to the resident related to culturally competent and / or trauma-informed care. F726, for concerns related to the knowledge, competencies, or skill sets of nursing staff to provide care or services that are culturally competent and trauma-informed. F742, for concerns related to treatment and services for resident with history of trauma and / or history of post-traumatic stress disorder, PTSD. Investigative procedures. Use the critical element C pathway associated with the issue under investigation, or if there is no specific CE pathway, use the general critical element pathway, along with the above interpretive guidelines when determining if the facility meets the requirements for, or investigating concerns related to the facility's requirement to develop and implement a comprehensive care plan. If systemic concerns are identified with comprehensive care plans, use the probes below to assist in your investigation. Probes. Does the care plan address the goals, preferences, needs, and strengths of the resident, including those identified in the comprehensive resident assessment, to assist the resident to attain or maintain his or her highest practicable well-being and prevent avoidable decline? Are objectives and interventions person-centered, measurable, and do they include time frames to achieve the desired outcomes? Is there evidence of resident and, if applicable, resident representative participation or attempts made by the facility to encourage participation in developing person-centered, measurable objectives and interventions? Does the care plan describe specialized services and interventions to address PASAR recommendations as appropriate? Does the care plan describe interventions that reflect the resident's cultural preferences, values, and practices? For residents with a history of trauma, does the care plan describe corresponding interventions for care that are in accordance with professional standards of practice and accounting for residents' experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident? See Section 483.2(5)(m). Is there evidence that care plan interventions were implemented consistently across all shifts? Is there a process in place to ensure direct care staff are aware of and educated about the care plan interventions? Determine whether the facility has provided adequate information to the resident and, if applicable, resident representative, so that he/she was able to make informed choices regarding treatment and services. Evaluate whether the care plan reflects the facility's efforts to find alternative means to address care of the resident if he or she has refused treatment. Potential tags for additional investigation. F658, for concerns regarding the delivery of care within professional standards of practice. If the surveyor identifies concerns about the resident's care plan being individualized and person-centered, The surveyor should also review requirements at Resident Rights, Section 483.10. Resident Assessment, Section 483.20. Activities, Section 483.24c. Nursing Services, Section 483.35. Food and Nutrition Services, Section 483.60. Facility Assessment, Section 483.71. Cultural Competence and Trauma-Informed Care, Section 483.25m. Treatment/Services for Mental/Psychosocial Concerns, Section 483.40b1. Key Elements of Noncompliance. To cite deficient practice at F656, the surveyor's investigation will generally show that the facility failed to do one or more of the following. Develop and implement a care plan that O is comprehensive and individualized. O is consistent with the resident's goals and right to be informed and participate in his or her treatment. O meets each of the medical, nursing, mental, and psychosocial needs identified on the resident's comprehensive assessment. O includes measurable objectives, interventions, and timeframes for how staff will meet the resident's needs. Develop and implement a care plan that describes all of the following. O resident goals and desired outcomes. O the care/services that will be furnished so that the resident can attain or maintain his or her highest practicable physical, mental, and psychosocial well-being. O the specialized services to be provided as a result of the PASAR evaluation and or the comprehensive assessment. O the resident's discharge plan and any referrals to the local contact agency. O refusals of care and action taken by facility staff to educate the resident and resident representative, if applicable, regarding alternatives and consequences. O care and services which are culturally competent and trauma-informed. Deficiency categorization. Examples of Level 4, immediate jeopardy to resident health and safety, include, but are not limited to, a resident has a known history of inappropriate sexual behaviors and aggression, but the comprehensive care plan did not address the resident's inappropriate sexual behaviors or aggression, which placed the resident and other residents in the facility at risk for serious physical and or psychosocial injury, harm, impairment, or death. The facility failed to implement care plan interventions to monitor a resident with a known history of elopement attempts, which resulted in the resident leaving the building unsupervised, putting the resident at risk for serious injury or death. The facility failed to identify a resident's cultural dietary restrictions related to eating pork. After eating her dinner, upon realization that she had eaten pork, the resident began crying inconsolably and screaming that this was explicitly forbidden in her culture and faith of Islam. The resident remained tearful and inconsolable for several days and would not eat the food provided by the facility, which resulted in weight loss and serious psychosocial harm. Examples of Level 3, actual harm that is not immediate jeopardy include, but are not limited to. The CAA summary for a resident indicates the need for a care plan to be developed to address nutritional risks in a resident who had poor nutritional intake. A care plan was not developed, or the care plan interventions did not address the problems/risks identified. The lack of interventions caused the resident to experience weight loss. Lack of care plan interventions to address a resident's anxiety, depression, and hallucinations resulted in psychosocial harm to the resident. Examples of Level 2, no actual harm, with potential for more than minimal harm, that is not immediate jeopardy, include, but are not limited to. During the comprehensive assessment, a resident indicated a desire to participate in particular activities, but the comprehensive care plan did not address the residents' preferences for activities, which resulted in the resident complaining of being bored and sometimes feeling sad about not participating in activities she expressed interest in attending. An inaccurate or incomplete care plan resulted in facility staff providing one staff to assist the resident when the resident required the assistance of two staff, which had the potential to cause more than minimal harm. An example of Level 1, no actual harm with potential for no more than a minor negative impact on the resident includes, but is not limited to. For one or more care plans, the staff did not include a measurable objective, which resulted in no more than a minor negative impact on the involved residents. Tag F657. Section 483.21b, Comprehensive Care Plans. Section 483.21b2, a comprehensive care plan must be developed within 7 days after completion of the comprehensive assessment. Roman 2, prepared by an interdisciplinary team, that includes but is not limited to A. The attending physician. B. A registered nurse with responsibility for the resident. C. A nurse aide with responsibility for the resident. D. A member of food and nutrition services staff. E. To the extent practicable, the participation of the resident and the residents. Representative S. An explanation must be included in a resident's medical record if the participation of the resident and their resident representative is determined not practicable for the development of the resident's care plan. F. Other appropriate staff or professionals in disciplines as determined by the resident's needs or as requested by the resident. Roman 3, reviewed and revised by the interdisciplinary team after each assessment, including both the comprehensive and quarterly review assessments. Intent of Section 483.21b2. To ensure the timeliness of each resident's person-centered, comprehensive care plan, and 2. Ensure that the comprehensive care plan is reviewed and revised by an interdisciplinary team composed of individuals who have knowledge of the resident and his or her needs, and that each resident and resident representative, if applicable, is involved in developing the care plan and making decisions about his or her care. Definitions. Non-physician practitioner NPP is a nurse practitioner NP, clinical nurse specialist. CNS, or physician assistant PA. Guidance section 483.21b2. Facility staff must develop the comprehensive care plan within 7 days of the completion of the comprehensive assessment admission, annual or significant change in status and review, and revise the care plan after each assessment. After each assessment means after each assessment known as the Resident Assessment Instrument RI, or Minimum Data Set MDS. As required by Section 483.20, except discharge assessments. For newly admitted residents, the comprehensive care plan must be completed within 7 days of the completion of the comprehensive assessment and no more than 21 days after admission. As used in this requirement, interdisciplinary means that professional disciplines, as appropriate, will work together to provide the greatest benefit to the resident. It does not mean that every goal must have an interdisciplinary approach. The mechanics of how the interdisciplinary team, IT, meets its responsibilities in developing an interdisciplinary care plan, e.g., a face-to-face meeting, teleconference, written communication is at the discretion of the facility. In instances where an IDT member participates in care plan development, review, or revision via written communication, the written communication in the medical record must reflect involvement of the resident and resident representative, if applicable, and other members of the IDT as appropriate. The IDT must, at a minimum, consist of the resident's attending physician, a registered nurse, and nurse aide with responsibility for the resident, a member of the food and nutrition services staff. And to the extent possible, the resident and resident representative, if applicable, if the attending physician is unable to participate in the development of the care plan, he/she may delegate participation to an NPP who is involved in the resident's care, to the extent permitted by state law, or arrange alternative methods of providing input in the development and revision of the care plan, such as one-on-one discussions, video conferencing, and conference calls with the IDT. The determination of other appropriate staff or professionals' participation in the IDT should be based on the physical, mental, and psychosocial condition of each resident. This includes an appropriate level of involvement of physicians, nurses, rehabilitation therapists, activities, professionals, social workers, and other professionals, such as developmental disabilities, specialists, or spiritual advisor. Involvement of other individuals is dependent upon resident request and/or needs. Each resident has the right to participate in choosing treatment options and must be given the opportunity to participate in the development, review, and revision of his or her care plan. Residents also have the right to refuse treatment. Facility staff have a responsibility to assist residents to engage in the care planning process, e.g., helping residents and resident representatives, if applicable, understand the assessment and care planning process, holding care planning meetings at the time of day when the resident is functioning best, planning enough time for information exchange and decision-making, encouraging a resident's representative to participate in care planning and attend care planning conferences. The facility must provide the resident and resident representative, if applicable, with advance notice of care planning conferences to enable resident/resident representative participation. Resident and resident representative participation in care planning can be accomplished in many forms, such as holding care planning conferences at a time the resident representative is available to participate, holding conference calls or video conferencing. Facilities are expected to facilitate the residents and, if applicable, the resident representatives' participation in the care planning process. There are limited circumstances in which the inclusion of the resident and/or resident representative may not be practicable or feasible. An example may be the case of a severely cognitively impaired resident who is unable to understand or participate in care plan development, and the resident's representative does not respond to facility attempts to make contact. If the facility determines that the inclusion of the resident and/or resident representative is not practicable, documentation of the reasons, including the steps the facility took to include the resident and/or resident representative, must be included in the medical record. While federal regulations at Section 483.10c affirm the resident's right to participate in care planning, request and/or refuse treatment, the regulations do not create the right for a resident or resident representative, if applicable, to demand that the facility use specific medical interventions or treatments that the facility deems not medically necessary and/or reasonable. The resident's care plan must be reviewed after each assessment, as required by Section 483.20, except discharge assessments, and revised based on changing goals, preferences, and needs of the resident and in response to current interventions. Note, although federal requirements dictate the completion of RAI assessments according to certain time frames, standards of good clinical practice dictate that the clinical assessment process is more fluid and should be ongoing. The lack of ongoing clinical assessment and identification of changes in condition to meet the resident's needs between required RAI. Assessments should be addressed at Section 483.35, Nursing Services, F626 Competency and Skills to identify and address a change in condition, and the relevant outcome tag, such as Section 483.12. Abuse, Section 483.24, Quality of Life, Section 483.25, Quality of Care, and / or Section 483.40, Behavioral Health. For concerns related to the resident's rights to participate in planning and implementing his or her care, see requirements at Section 483.10c. Investigative Summary and Probes Section 483.21b2. Use the critical element C pathway associated with the issue under investigation, or if there is no specific CE pathway, use the general critical element pathway, along with the above interpretive guidelines when determining if the facility meets the requirements for, or investigating concerns related to the facility's requirement for timely completion and IDT and resident involvement in the development of the comprehensive care plan, if systemic concerns are identified with timeliness and IDT/resident involvement in the development of comprehensive care plans, use the probes below to assist in your investigation. Was a comprehensive plan of care developed within 7 days of completion of the resident's comprehensive assessment? Is there evidence of participation in the care planning process by required IDT members? Ask required members of the IDT how they participate in the development, review, and revision of care plans, based on the resident's goals and needs, were other appropriate staff or professionals. Expertise utilized to develop a plan to improve the resident's functional abilities. For example, A. Did an occupational therapist recommend needed adaptive equipment or a speech therapist provide techniques to improve swallowing ability? B. Did the dietitian and speech therapist determine the optimum textures and consistency for the resident's food that is nutritionally adequate and compatible with the resident's oropharyngeal capabilities and food preferences? Is there evidence of attending physician involvement in development of the care plan, e.g., presence at care plan meetings, conversations with team members concerning the care plan, conference calls, written communication? How do staff make an effort to schedule care plan meetings at the best time of the day for residents and, if applicable, the resident representatives? How do staff make the care plan process understandable to the resident and resident representative, if applicable? Ask the resident and resident representative, if applicable, if he or she actively participates in the care planning process. If not, what have been the barriers to participation? Ask the resident, and if applicable, the resident representative if he or she has requested the participation of additional individuals' care planning process. If so, was the request respected? In what ways does staff involve the resident and, if applicable, the resident representative in care planning? If staff determine that the resident and / or resident representative involvement in care planning is not practicable, is the reason and the steps the facility took to include the resident and / or resident representative documented in the medical record? Is there evidence that the care plan is evaluated for effectiveness and revised following each required assessment, except discharge assessments, and as needed? Deficiency categorization. An example of Level 4, immediate jeopardy to resident health or safety, includes, but is not limited to, the resident's care plan was not revised following a significant change assessment which identified an occurrence of resident-to-resident sexual abuse, placing the abused resident and other residents at risk for serious injury, impairment, or death. An example of Level 3, actual harm that is not immediate jeopardy includes, but is not limited to. The facility failed to develop the comprehensive care plan within 7 days of completion of the comprehensive assessment. This resulted in the resident sustaining a laceration requiring stitches due to a fall because appropriate fall prevention interventions were not implemented timely. Examples of Level 2, no actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to. Residents and their representatives, if applicable, are not routinely invited to participate in care planning, while the resident did not experience an actual decline in physical, mental, or psychosocial functioning and continued to meet goals established on the care plan. The care plan goals did not show evidence of resident and, if applicable, the resident representative input having the potential for more than minimal harm. Direct care staff were not made aware of revisions to the resident's care plan by the IDT for 3 days to assist the resident in brushing his teeth. This resulted in staff not assisting the resident with brushing his teeth for 3 days, and the resident did not suffer actual harm. Examples of Level 1, no actual harm with potential for no more than a minor negative impact on the resident include, but are not limited to. Care plan was not reviewed by the IDT after the resident's quarterly assessment indicated a minor change in the resident's status. A required member of the IDT did not participate in development of the resident's care plan, which had no more than a minor negative impact to the resident. Tag F658. Section 483.2, 1B3, Comprehensive Care Plans. The services provided or arranged by the facility, as outlined by the Comprehensive Care Plan must meet professional standards of quality. Intent Section 483.21B3I. The intent of this regulation is to assure that services being provided meet professional standards of quality. Guidance Section 483.21B3I. Professional standards of quality means that care and services are provided according to accepted standards of clinical practice. Standards may apply to care provided by a particular clinical discipline or in a specific clinical situation or setting. Standards regarding quality care practices may be published by a professional organization, licensing board, accreditation body, or other regulatory agency. Recommended practices to achieve desired resident outcomes may also be found in clinical literature. Possible reference sources for standards of practice include current manuals or textbooks on nursing, social work, physical therapy, etc. Standards published by professional organizations such as the American Dietetic Association, American Medical Association, American Medical Directors Association, American Nurses Association, National Association of Activity Professionals, National Association of Social Work, etc. Clinical practice guidelines published by the Agency for Healthcare Research and Quality. Current professional journal articles. Note, although federal requirements dictate the completion of RAI assessments according to certain time frames, standards of good clinical practice dictate that the clinical assessment process is more fluid and should be ongoing. The lack of ongoing clinical assessment and identification of changes in condition to meet the resident's needs between required RAI assessments should be addressed at Section 483.35, Nursing Services, F656 Competency and Skills to identify and address a change in condition, and the relevant outcome tag, such as Section 483.12. Abuse, Section 483.24, Quality of Life, Section 483.25, Quality of Care, and / or Section 483.40 Behavioral Health. Note: CMS is aware of situations where practitioners have potentially misdiagnosed residents with a condition for which antipsychotics are an approved use, e.g., new diagnosis of schizophrenia, which would then exclude the resident from the long-stay antipsychotic quality measure. For these situations, determine if noncompliance exists related to the practitioner not adhering to professional standards of quality for assessing and diagnosing a resident. This practice may also require referrals by the facility and / or the survey team to state medical boards or boards of nursing. Procedures and Probes Section 483.21b3i. There is no requirement for the surveyor to cite a reference or source, e.g., current textbooks, professional organizations, or clinical practice guidelines for the standard of practice that has not been followed related to care and services provided within professional scopes of practice, such as failure of nursing staff to assess a change in the resident's condition. However, in cases where the facility provides a reference supporting a particular standard of practice for which the surveyor has concerns, the surveyor must provide evidence that the standard of practice the facility is using is not up to date, widely accepted, or supported by recent clinical literature. Such evidence should include a citation for the reference or source, e.g., current textbooks, professional organizations, or clinical practice guidelines for the current standard of practice from which facility deviated. If a negative or potentially negative resident outcome is determined to be related to the facility's failure to meet professional standards and the team determines a deficiency has occurred, it should also be cited under the appropriate quality of care or other relevant requirement. For example, if a resident develops a pressure injury because the facility's nursing staff failed to provide care in accordance with professional standards of quality, the team should cite the deficiency at both F658 and F686 skin integrity. Do the services provided or arranged by the facility, as outlined in the comprehensive care plan, reflect accepted standards of practice? Are the references for standards of practice used by the facility up to date and accurate for the service being delivered? Key elements of noncompliance. To cite deficient practice at F658, the surveyor's investigation will generally show that the facility did one or more of the following: provided or arranged for services or care that did not adhere to accepted standards of quality, provided a service or care when the accepted standards of quality dictate that the service or care should not have been provided, failed to provide or arrange for services or care that accepted standards of quality dictate should have been provided. Tag F659. Section 483.2, 1b3, Comprehensive Care Plans. The services provided or arranged by the facility, as outlined by the Comprehensive Care Plan must II be provided by qualified persons in accordance with each resident's written plan of care. Guidance. The facility must ensure that services provided or arranged in accordance with the resident's plan of care are delivered by individuals who have the skills, experience, and knowledge to do a particular task or activity. This includes proper licensure or certification, if required. Investigative procedures and probes. Note: provision of services by qualified individuals would be cited here, but implementation of the care plan would be cited in F656. Are the services identified in the Comprehensive Care Plan being provided by qualified persons? Do staff assigned to the resident have the skills, experience, and knowledge to provide care and services that meet the resident's needs? Deficiency categorization. An example of Level 4, immediate jeopardy to resident health or safety includes, but is not limited to, the facility had no qualified staff on duty knowledgeable or competent in how to care for a resident with a tracheostomy, posing a risk for serious injury, harm, impairment, or death for the resident. An example of Level 3, actual harm that is not immediate jeopardy includes, but is not limited to, the facility utilized a staff member who was not qualified to draw a resident's blood according to the resident's care plan, resulting in the resident sustaining extensive bruising, swelling, pain, and decreased ability to use the arm after the blood draw. An example of Level 2, no actual harm with potential for more than minimal harm. That is not immediate jeopardy includes, but is not limited to, the facility failed to ensure staff were qualified to perform blood pressure BP readings. During survey, staff were observed taking and reporting resident BPs that were abnormal. After further investigation, it was determined that staff were using the incorrect size BP cuff, yielding inaccurate BP readings, resulting in the potential for more than minimal harm. Non-compliance with this regulation places the resident at risk for more than minimal harm. Therefore, Severity Level 1 does not apply for this regulatory requirement. Tag F660. Section 483.2, 1C1 Discharge Planning Process. The facility must develop and implement an effective discharge planning process that focuses on the resident's discharge goals, the preparation of residents to be active partners, and effectively transition them to post-discharge care, and the reduction of factors leading to preventable readmissions. The facility's discharge planning process must be consistent with the discharge right set forth at 483.1, 5b, as applicable, and I ensure that the discharge needs of each resident are identified and result in the development of a discharge plan for each resident. Roman 2, include regular reevaluation of residents to identify changes that require modification of the discharge plan. The discharge plan must be updated as needed to reflect these changes. Roman 3 involve the interdisciplinary team, as defined by Section 483.21b2 Roman 2, in the ongoing process of developing the discharge plan. Roman 4, consider caregivers/support person availability and the residents or caregivers/support person's capacity and capability to perform required care as part of the identification of discharge needs. V involve the resident and resident representative in the development of the discharge plan and inform the resident and resident representative of the final plan. Roman 6, address the resident's goals of care and treatment preferences. Roman 7, document that a resident has been asked about their interest in receiving information regarding returning to the community. A, if the resident indicates an interest in returning to the community, the facility must document any referrals to local contact agencies or other appropriate entities made for this purpose. B, facilities must update a resident's comprehensive care plan and discharge plan as appropriate in response to information received from referrals to local contact agencies or other appropriate entities. C, if discharge to the community is determined to not be feasible, the facility must document who made the determination and why. Roman 8, for residents who are transferred to another SNF or who are discharged to a HHA, IRF, or LTCH, assist residents and their resident representatives in selecting a post-acute care provider by using data that includes, but is not limited to SNF, HHA, IRF, or LTCH standardized patient assessment data, data on quality measures, and data on resource use to the extent the data is available, The facility must ensure that the post-acute care standardized patient assessment data on quality measures, and data on resource use is relevant and applicable to the residents' goals of care and treatment preferences. Roman 9 document, complete on a timely basis based on the resident's needs, and include in the clinical record the evaluation of the resident's discharge needs and discharge plan. The results of the evaluation must be discussed with the resident or residents' representative. All relevant resident information must be incorporated into the discharge plan to facilitate its implementation and to avoid unnecessary delays in the resident's discharge or transfer. Intent Section 483.21c1. This requirement intends to ensure that the facility has a discharge planning process in place, which addresses each resident's discharge goals and needs, including caregiver support and referrals to local contact agencies as appropriate, and involves the resident and, if applicable, the resident representative and the interdisciplinary team in developing the discharge plan. Definitions, Section 483.21c1. Discharge planning, a process that generally begins on admission and involves identifying each resident's discharge goals and needs, developing and implementing interventions to address them, and continuously evaluating them throughout the resident's stay to ensure a successful discharge. Home Health Agency, HHA, a public agency or private organization or a subdivision of either which is primarily engaged in providing skilled nursing services and other therapeutic services in the patient's home and meets the requirements of Sections 1861 and 1890 of the Social Security Act. Inpatient Rehabilitation Facility (IRF) are freestanding rehabilitation hospitals or rehabilitation units in acute care hospitals that serve an inpatient population requiring intensive services for treatment. Local Contact Agency refers to each state's designated community contact agencies that can provide individuals with information about community living options and available supports and services. These local contact agencies may be a single entry point agency, such as an Aging and Disability Resource Center at RC, an area agency on aging AAA, a center for independent living SIL, or other state-designated entities. Long-term care hospital LTCH are certified as acute care hospitals but focus on patients who, on average, stay more than 25 days. Many of the patients in LTCHs are transferred. They're from an intensive or critical care unit. LTCHs specialize in treating patients who may have more than one serious condition, but who may improve with time and care and return home. Patient assessment data, standardized, publicly available information derived from a post. Acute care providers' patient/resident assessment instrument, e.g., minimum data set MDS. Outcome and assessment information, set OASIS. Guidance Section 483.21c1. Discharge planning. Discharge planning is the process of creating an individualized discharge care plan, which is part of the comprehensive care plan. It involves the interdisciplinary team as defined in Section 483.21b2 Roman 2, working with the resident and resident representative, if applicable, to develop interventions to meet the resident's discharge goals and needs to ensure a smooth and safe transition from the facility to the post-discharge setting. Discharge planning begins at admission and is based on the resident's assessment and goals for care, desire to be discharged, and the resident's capacity for discharge. It also includes identifying changes in the resident's condition, which may impact the discharge plan, warranting revisions to interventions. A well-executed discharge planning process without avoidable complications, maximizes each resident's potential to improve, to the extent possible, based on his or her clinical condition. An inadequate discharge planning process may complicate the resident's recovery, lead to admission to a hospital, or even result in the resident's death. The discharge care plan is part of the comprehensive care plan and must be developed by the interdisciplinary team and involve direct communication with the resident and, if applicable, the resident representative. Address the resident's goals for care and treatment preferences. Identify needs that must be addressed before the resident can be discharged, such as resident education, rehabilitation, and caregiver support and education. Be reevaluated regularly and updated when the resident's needs or goals change. Document the resident's interest in and any referrals made to the local contact agency. Identify post-discharge needs such as nursing and therapy services, medical equipment, or modifications to the home or ADL assistance. Resident discharge to the community. Section Q of the Minimum Data Set MDS requires that individuals be periodically assessed for their interest in being transitioned to community living, unless the resident indicates otherwise. See https://www.cms.gov/Medicare/Quality Initiatives Patient Assessment. Instrument/Nursing Home Quality in its /NHCMDs 30 Training Materials HTML. For residents who want to be discharged to the community, the nursing home must determine if appropriate and adequate supports are in place, including capacity and capability of the residents. Caregivers at home, family members, significant others, or the resident's representative should be involved in this determination with the resident's permission, unless the resident is unable to participate in the discharge planning process. Each situation is unique to the resident, his or her family, and / guardian / legally authorized representative. A referral to the local contact agency LCA may be appropriate for many individuals who could be transitioned to a community setting of their choice. The nursing home staff is responsible for making referrals to the LCA, if appropriate, under the process that the state has established. Nursing home staff should also make the resident, and if applicable, the resident representative aware that the local ombudsman is available to provide information and assist with any transitions from the nursing home. For residents who have been in the facility for a longer time, it is still important to inquire, as appropriate, whether the resident would like to talk with LCA experts about returning to the community. New or improved community resources and supports may have become available since the resident was first admitted, which may now enable the resident to return to a community setting. If the resident is unable to communicate his or her preference, or is unable to participate in discharge planning, the information should be obtained from the resident's representative. Discharge planning must include procedures for documentation of referrals to local contact agencies, the local ombudsman, or other appropriate entities made for this purpose, documentation of the response to referrals, and for residents for whom discharge to the community has been determined to not be feasible, the medical record must contain information about who made that decision and the rationale for that decision. Discharge planning must identify the discharge destination and ensure it meets the resident's health and safety needs as well as preferences. If a resident wishes to be discharged to a setting that does not appear to meet his or her post-discharge needs or appears unsafe, the facility must treat this situation similarly to refusal of care and must discuss with the resident and / or his or her representative, if applicable, and document the implications and / or risks of being discharged to a location that is not equipped to meet his or her needs, and attempt to ascertain why the resident is choosing that location. Document that other, more suitable, options of locations that are equipped to meet the needs of the resident were presented and discussed. Document that despite being offered other options that could meet the resident's needs, the resident refused those other more appropriate settings. Determine if a referral to Adult Protective Services or other state entity charged with investigating abuse and neglect is necessary. The referral should be made at the time of discharge. As appropriate, facilities should follow their policies or state law as related to discharges which are against medical advice. Residents who will be discharged to another SNF/NF, HHA, IRF, or LTCH. If a resident will be discharged to another SNF, an IRF, LTCH, or HHA, the facility must assist the resident in choosing an appropriate post-acute care provider that will meet the resident's needs, goals, and preferences. Assisting the resident means the facility must compile available data on other appropriate post-acute care options to present to the resident. Information the facility must gather about potential receiving providers includes, but is not limited to, publicly available standardized quality information, as reflected in specific quality measures such as the CMS Nursing Home Compare, Home Health Compare, Inpatient Rehabilitation Facility IRF Compare, and Long-Term Care Hospital LTCH Compare. Websites and resource use data, which may include number of residents/patients who are discharged to the community, and rates of potentially preventable hospital readmissions. The listing of potential providers and data compiled must be relevant to the resident's needs and be aligned with the resident's goals of care and treatment preferences. Facilities must also comply with Section 1128B of the Social Security Act, the federal anti-kickback statute, when making referrals to other provider types. Section 1128B prohibits the knowing and willful offer, payment, solicitation, or receipt of any remuneration, in cash or in kind, to induce or in return for referring an individual for the furnishing or arranging of any item or service for which payment may be made under a federal health care program. https://www.cms.gov/Medicare Medicaid Coordination/Fraud Prevention /Medicaid Integrity. Education/downloads/FWA Laws Resource Guide PDF. In order to emphasize resident involvement, facilities are expected to present provider information to the resident and resident representative, if applicable, in an accessible and understandable format. For example, the facility should provide the aforementioned quality data on other post-acute care providers that meet the resident's needs, goals, and preferences, and are within the resident's desired geographic area. Facilities must then assist residents and or resident representative as they seek to understand the data and use it to help them choose a post-acute care provider or other setting for discharge that is best suited to their goals, preferences, needs, and circumstances. For residents who are discharged to another SNF/NF, a HHA, IRF, or LTCH, the facility must provide evidence that the resident, and if applicable, the resident representative, was given provider information that includes standardized patient assessment data and information on quality measures and resource use where that data is available. Potential tags for additional investigation. F624, for concerns related to the immediate orientation and preparation necessary for a transfer, which does not require discharge planning, such as transfers to a hospital emergency room or therapeutic leave. Summary of investigative procedures. Use the community discharge critical element C pathway, along with the above interpretive Guidelines when determining if the facility meets the requirements for or investigating concerns related to the facility's requirement to develop and implement an effective discharge planning process. Briefly review the most recent comprehensive assessments, comprehensive care plan, specifically the discharge care plan, progress notes, and orders to identify whether the facility has identified and addressed the residents' goals and discharge needs. This information will guide observations and interviews to be made in order to corroborate concerns identified. If there are concerns related to systematic discharge planning, this may trigger a review of the nursing home's policies and procedures for discharge assessment and care planning. Note: always observe for visual cues of psychosocial distress and harm. See Appendix P. Guidance on severity and scope levels and psychosocial outcome severity guide. Deficiency categorization. An example of Level 4, immediate jeopardy to resident health or safety, includes, but is not limited to, the facility failed to ensure that the post-discharge destination and continuing care provider could meet the resident's needs prior to the discharge of a resident with a feeding tube to a residential group facility. The surveyor discovered that within 24 hours of discharge, the resident was transferred to the hospital for aspiration, was intubated for respiratory distress, and diagnosed with brain death. Review of medical records showed no documentation of the resident's tube feeding needs in the discharge plan, or whether the nursing home informed the receiving facility of the presence of the feeding tube and the need for aspiration precautions. It was also unclear whether the nursing home had determined that the receiving facility had the ability to care for a resident with a feeding tube prior to placement of the individual. Examples of Level 3, actual harm that is not immediate jeopardy include, but are not limited to, the facility failed to develop and or implement a discharge care plan for a resident who had expressed a desire to return home as soon as possible once she completed rehabilitation for a fractured hip. The medical record revealed the therapist had discontinued the active treatment 1 week ago. The resident stated, and the medical record verified that the facility had not developed plans for her care after her discharge and had not contacted any community providers to assist in her discharge. She indicated that she has not slept well due to worrying about returning to her home and paying the rent while in the facility. The resident's home was over an hour away. She stated she was depressed over having to remain in the nursing home and spent most of the day in her room as it was too far for her friends to visit. A facility failed to develop discharge plans to meet the needs and goals of each resident, resulting in significant psychosocial harm when the facility determined it would be closing, necessitating the discharge of all residents. The facility notified residents and resident representatives it would assist with relocation. Interviews with residents and observations showed residents were agitated, fearful, and in tears over the impending move. Residents indicated they were not asked their preferences, and many would be relocated far away from family. Residents also indicated they were not given opportunities to provide input into the discharge planning process, specifically regarding discharge location. Record review showed no evidence of interaction with residents or resident representatives related to discharge planning. This was cross-referenced and cited at F655, facility closure. An example of Level 2, no actual harm with potential for more than minimal harm that is not immediate jeopardy includes, but is not limited to, facility failed to develop a discharge care plan that addressed all of the needs for a resident being discharged home. Specifically, the care plan did not address the resident's need for an oxygen concentrator at home, After the resident was discharged to his home, a family member had to contact the physician to obtain the order and make arrangements for delivery of the equipment, although there was a delay in obtaining the oxygen concentrator. The resident did not experience harm. However, this 4-hour delay had a potential for compromising the resident's ability to maintain his well-being. Severity Level 1 does not apply for this regulatory requirement. The failure of the facility to provide appropriate discharge assessment and planning in order to meet the resident's needs and goals at the time of discharge from the nursing home and to ensure communication of necessary information for a safe transition of care places the resident at risk for more than minimal harm. Tag F661. Section 483.2, 1C2 Discharge Summary. When the facility anticipates discharge, a resident must have a discharge summary that includes, but is not limited to, the following. A recapitulation of the resident's stay that includes, but is not limited to, diagnosis, course of illness/treatment or therapy, and pertinent lab, radiology, and consultation results. Roman 2, a final summary of the resident's status to include items in paragraph B1 of Section 483.20 at the time of the discharge that is available for release to authorized persons and agencies with the consent of the resident or resident's representative. Roman 3, reconciliation of all pre-discharge medications with the resident's post-discharge medications, both prescribed and over-the-counter. Roman 4, a post-discharge plan of care that is developed with the participation of the resident and, with the resident's consent, the resident representative S, which will assist the resident to adjust to his or her new living environment. The post-discharge plan of care must indicate where the individual plans to reside, any arrangements that have been made for the resident's follow-up care, and any post-discharge medical and non-medical services. Intent of Section 483.21C2. To ensure the facility communicates necessary information to the resident, continuing care provider, and other authorized persons at the time of an anticipated discharge. Definitions, Section 483.21C2. Anticipated discharge, a discharge that is planned and not due to the resident's death or an emergency, e.g., hospitalization for an acute condition or emergency evacuation. Continuing care provider, the entity or person who will assume responsibility for the resident's care after discharge. This includes licensed facilities, agencies, physicians, practitioners, and or other licensed caregivers. Recapitulation of stay, a concise summary of the resident's stay and course of treatment in the facility. Reconciliation of medications, a process of comparing pre-discharge medications to post-discharge medications by creating an accurate list of both prescription and over-the-counter medications that includes the drug name, dosage, frequency, route, and indication for use for the purpose of preventing unintended changes or omissions at transition points in care. Guidance Section 483.21C2. Overview. The discharge summary provides necessary information to continuing care providers pertaining to the course of treatment while the resident was in the facility and the resident's plans for care. After discharge, a discharge summary must include an accurate and current description of the clinical status of the resident and sufficiently detailed, individualized care instructions to ensure that care is coordinated and the resident transitions safely from one setting to another. The discharge summary may help reduce or eliminate confusion among the various facilities, agencies, practitioners, and caregivers involved with the resident's care. In the case of discharge to a non-institutional setting, such as the resident's home, provision of a discharge summary with the resident's consent to the resident's community-based physicians/practitioners allows the resident to receive continuous and coordinated, person-centered care for residents who are being discharged from the facility to another health care facility. The discharge summary enables the receiving facility to provide appropriate and timely care. The medical record must identify the receiving facilities for which or physicians/practitioners to whom the discharge summary is provided. Content of the discharge summary. Recapitulation of resident stay. Recapitulation of the resident's stay describes the resident's course of treatment while residing in the facility. The recapitulation includes, but is not limited to, diagnosis, course of illness, treatment and/or therapy, and pertinent lab, radiology, and consultation results, including any pending lab results. Final summary of resident status. In addition to the recapitulation of the resident's stay, the discharge summary must include a final summary of the resident's status, which includes the items from the resident's most recent comprehensive assessment identified at Section 483.20b1I, Roman 18 Comprehensive Assessment. This is necessary to accurately describe the current clinical status of the resident. Items required to be in the final summary of the resident's status are identification and demographic information, customary routine, cognitive patterns, communication, vision, mood and behavior patterns, psychosocial well-being, physical functioning and structural problems, continence, disease diagnosis and health conditions, dental and nutritional status, skin condition, activity pursuit, medications, special treatments and procedures, discharge planning as evidenced by most recent discharge care plan, documentation of summary information regarding the additional assessment performed on the care areas triggered by the completion of the MDS, and documentation of participation in assessment. This refers to documentation of who participated in the assessment process. The assessment process must include direct observation and communication with the resident, as well as communication with licensed and non-licensed direct care/direct access staff members on all shifts. Note, in addition to the above, pursuant to Section 483.15C2 Roman 3, the facility transferring nursing home must convey the following information to the receiving provider when a resident is discharged or transferred from that facility. Contact information of the practitioner at the transferring nursing home responsible for the care of the resident. Resident representative information, if applicable, including contact information. Advance directive information. All special instructions or precautions for ongoing care, as appropriate. Comprehensive care plan goals, and all other necessary information, including a copy of the resident's discharge summary, consistent with Section 483.21C2 as applicable, and any other documentation, as applicable, to ensure a safe and effective transition of care. For concerns related to the above, see guidance at F622, Section 483.15C2 Roman 3. Timing of the discharge summary. The discharge summary contains necessary medical information that the facility must furnish at the time the resident leaves the facility to the receiving provider assuming responsibility for the resident's care after discharge. The discharge summary may be furnished in either hard copy or electronic format if the provider assuming responsibility for the resident's care has the capacity to receive and use the discharge summary in electronic format. Delays in preparing and forwarding the discharge summary hinder the coordination required to provide optimal care to the resident. The medical record must contain the discharge summary information and identify the recipient of the summary. Note, in situations where there is no continuing care provider, e.g., resident has no primary care physician in the community, the facility is expected to document in the medical record efforts to assist the resident in locating a continuing care provider. Reconciliation of medications prior to discharge. A resident's discharge medications may differ from what the resident was receiving while residing in the facility. Facility staff must compare the medications listed in the discharge summary to medications the resident was taking while residing in the nursing home. Any discrepancies or differences found during the reconciliation must be assessed and resolved, and the resolution documented in the discharge summary, along with a rationale for any changes. For example, a resident who is receiving rehabilitative services may have required antibiotic therapy postoperatively, but does not need to continue the antibiotic at home. The discontinuation of the medication should be documented in the discharge summary. Discharge instructions and accompanying prescriptions provided to the resident, and if applicable, the resident representative must accurately reflect the reconciled medication list in the discharge summary. Post-discharge plan of care. The post-discharge plan of care details the arrangements that facility staff have made to address the resident's needs after discharge, and includes instructions given to the resident and his or her representative, if applicable. The post-discharge plan of care must be developed with the participation of the interdisciplinary team and the resident, and with the resident's consent, the resident's representative. At the resident's request, a representative of the local contact agency may also be included in the development of the post-discharge plan of care. The post-discharge plan of care should show what arrangements have been made regarding where the resident will live after leaving the facility, follow-up care the resident will receive from other providers, and that provider's contact information, needed medical and non-medical services, including medical equipment, community care and support services, if needed, and when and how to contact the continuing care provider. Instructions to residents discharged to home. For residents discharged to their home, the medical record should contain documentation that written discharge instructions were given to the resident and, if applicable, the resident representative. These instructions must be discussed with the resident and resident representative and conveyed in a language and manner they will understand. Key elements of noncompliance. To cite deficient practice at F661, the surveyor's investigation will generally show that the facility failed to do one or more of the following. Prepare a discharge summary that includes all of the following. A recapitulation containing all required components of the resident's stay. A final summary of the resident's status that includes the items listed in Section 483.20b1. A reconciliation of all pre- and post-discharge medications. A discharge plan of care containing all required components, or reconcile the resident's pre-discharge medications with his or her post-discharge medications, or convey the discharge summary to the continuing care provider or receiving facility at the time of discharge. Deficiency categorization. An example of Level 4, immediate jeopardy to resident health or safety, includes, but is not limited to, a resident experienced a stroke during the SNF stay and was started on Coumadin. The resident was then discharged to another facility, but the discharge summary did not include the new orders for Coumadin and PT/INR monitoring. The receiving facility did not start the resident on Coumadin, and the resident experienced another stroke. An example of level 3, actual harm that is not immediate jeopardy includes, but is not limited to. Review of a discharge summary for a discharged resident showed that the discharge summary did not contain necessary information about the resident's wound care needs and arrangements for wound care after discharge. Investigation showed that the resident did not receive appropriate wound care at home because details of wound care received in the facility were not conveyed in the discharge summary. The facility's failure to provide instructions for the care of the wound in the discharge summary information caused the resident's wound to worsen at home, resulting in readmission to a hospital. An example of level 2, no actual harm with potential for more than minimal harm. That is not immediate jeopardy includes, but is not limited to. A resident was discharged to another facility closer to her family. The transferring facility did not send a complete discharge summary to the receiving facility until 1 week after the resident was admitted to the new facility. The receiving facility had to take additional time and use multiple sources to verify medications and other medical orders while waiting for a complete discharge summary. This placed the resident at risk for more than minimal harm due to the potential for inaccuracies in medication and other orders while waiting for a complete discharge summary. An example of level 1, no actual harm with potential for no more than a minor negative impact on the resident includes, but is not limited to, the failure of the facility to provide in its recapitulation of the resident's stay the most recent laboratory results which were normal. This resulted in no negative impact to the resident. Tag F655. Section 483.24, Quality of Life. Quality of life is a fundamental principle that applies to all care and services provided to facility residents. Each resident must receive, and the facility must provide the necessary care and services to attain or maintain the highest practicable physical, mental, and psychosocial well-being, consistent with the resident's comprehensive assessment and plan of care. Intent. The intent of this requirement is to specify the facility's responsibility to create and sustain an environment that humanizes and individualizes each resident's quality of life by ensuring all staff, across all shifts and departments, understand the principles of quality of life and honor and support these principles for each resident, and ensuring that the care and services provided are person-centered and honor and support each resident's preferences, choices, values, and beliefs. Definitions, Section 483.24. Person-centered care. For the purposes of this subpart, person-centered care means to focus on the resident as the locus of control and support the resident in making their own choices and having control over their daily lives. Definitions, Section 483.5. Pervasive. For the purposes of this guidance, pervasive means spread through or embedded within every part of something. Quality of life refers to an individual's sense of well-being, level of satisfaction with life, and feeling of self-worth and self-esteem. For nursing home residents, this includes a basic sense of satisfaction with oneself, the environment, the care received, the accomplishments of desired goals, and control over one's life. Adapted from the 1986 Institute of Medicine IM. Published report, Improving the Quality of Care in Nursing Homes, located at https://www.ncbinlmnigov/books/NBK 215548/DDD00037. Guidance section 483.24. Noncompliance at F655 identifies outcomes which rise to the level of immediate jeopardy and reflect an environment of pervasive disregard for the quality of life of the facility's residents. This can include the cumulative effect of noncompliance at other regulatory tags on one or more residents. To cite noncompliance at F675, the survey team must have evidence that outcomes at other regulatory tags demonstrate a pervasive disregard for the principles of quality of life. Principles of quality of life. According to the 1986 Institute of Medicine (IM) published report, Improving the Quality of Care in Nursing Homes, principles of quality of life included a sense of well-being, satisfaction with life, and feeling of self-worth and self-esteem, and a sense of satisfaction with oneself, the environment, the care received, the accomplishments of desired goals, and control over one's life. The report also identified that a sense of well-being, self-esteem, and self-worth was enhanced by personal control over choices, such as meal times, activities, clothing, and bedtime, privacy during visits and treatments, and opportunities to engage in religious, political, civic, recreational, or other social activities, based upon the regulatory requirement stating that quality of life is an overarching principle that applies to all care and services, the principles as identified in the IOM report above will be used for determining whether a resident's quality of life is being supported and/or enhanced. Refer to this link for the entire IOM report. https://www.ncbinlmnigov/books/NBK 217548/#DDD00037. Facilities must create and sustain an environment that humanizes and promotes each resident's well-being and feeling of self-worth and self-esteem. This requires nursing home leadership to establish a culture that treats each resident with respect and dignity as an individual and addresses, supports, and or enhances his or her feelings of self-worth, including personal control over choices such as meal times, activities, clothing, and bedtime, privacy during visits and treatments, and opportunities to engage in religious, political, civic, recreational, or other social activities. Facility leadership must be aware of the culture that exists in its facility and may use various methods to assess the attitudes and values prevalent among staff. These methods include reviewing complaints or grievances, which could reasonably impact a resident's quality of life, or allegations of abuse, neglect, or mistreatment, in order to identify whether staff supports each resident's quality of life. Leadership should observe and evaluate verbal and nonverbal interactions between staff and residents. Negative observations could include staff actions such as, but not limited to, the following: verbalizing negative or condescending remarks, or refusing to provide individualized care to a resident due to his or her age, race, or cognitive or physical impairments, his or her political or cultural beliefs, or sexual preferences. Dehumanizing an individual through verbal and nonverbal actions, such as talking to others over a resident without acknowledging his or her presence, treating the resident as if he/she were an object rather than a human being, mistreating or physically, sexually, or mentally abusing a resident. These types of staff actions and attitudes do not recognize nor value the individual. An individual's life experiences, values, needs, choices, and relationships must not be diminished to the extent possible due to admission to a nursing home. Treating a nursing home resident in any manner that does not uphold a resident's sense of self-worth, dignity, and individuality dehumanizes the resident and creates an environment that perpetuates an unhealthy, unsafe attitude towards the residentess. In order to achieve a culture and environment that supports quality of life, The facility must ensure that all staff, across all shifts and departments, understand the principles of quality of life and honor and support these principles for each resident, and that the care and services that are provided by the facility are person-centered and honor and support each resident's preferences, choices, values, and beliefs. The link between noncompliance at other regulatory tags and noncompliance at quality of life. Quality of life at F675 should not automatically be cited when noncompliance has been identified in residents' right/quality of care/abuse neglect or other regulatory tags, unless the cumulative effect of the noncompliance creates an environment that reflects a complete disregard of one or more residents' well-being and rises to the level of immediate jeopardy. See below for an example of noncompliance at F675, demonstrating the cumulative effect of noncompliance at other tags for multiple residents. The facility failed to provide an environment which supported and enhanced each resident's quality of life, which was the result of the cumulative effect of noncompliance. Cited at dignity, abuse, staffing, and continence care, this noncompliance was found to be pervasive and created an environment reflecting a complete disregard of one or more residents' well-being and quality of life, which has caused or is likely to cause serious harm related to one or more residents' self-worth, self-esteem, and well-being. A complaint investigation revealed facility staff members posted unauthorized videos and photographs on social media of several residents during bathing, going to the bathroom, and grooming, including nude photos and photos of genitalia. As a result, the residents suffered public humiliation and dehumanization. Facility staff interviewed were aware of this abuse, but did not report to administration due to fear of retaliation by the perpetrators and fear of losing their jobs. During a resident council meeting, several residents reported that they heard staff describing the photos, laughing about the postings, and had seen staff passing around cell phones. As a result, the residents stated that they were afraid to take a shower or bath and were extremely uncomfortable when requesting assistance to go to the bathroom because they thought it might happen to them and that they had shared these concerns with other residents in the facility. Refer to noncompliance cited at Section 483.12, F600. Abuse. When discussing going to the bathroom, the residents stated that in addition to being afraid of asking for help when they did, there were not enough staff to answer call lights. They said that staff would ignore their call light, walk by, or would answer the light and leave without assisting the residents. This had resulted in episodes of incontinence of urine and feces, which they stated was extremely embarrassing, humiliating, and degrading to them. Refer to noncompliance cited at Section 483.10A1. F550, Dignity. Section 483.35, F725, Insufficient Staff, Nursing Services, and Section 483.25E1. F690, Incontinence, Quality of Care. Several residents stated that they were afraid to ask for staff assistance for the need to use the bathroom based on their fear related to the postings on social media. In addition, they stated that when they were receiving care, if staff pulled out a cell phone, they didn't know if staff were taking and posting pictures of them. When asked if these concerns had been reported to the administration, the residents stated that they identified the issue with the call lights and not enough staff multiple times during council meetings, but that the administration only said, "We will look into it," and nothing was done. They said they were afraid to report the cell phone concerns. One resident said that an aide told him/her that if they didn't quit complaining to the administrator, no one would help them and they would be transferred to another Facility. When the resident began to cry, the aide laughed and walked out of the room, verbally taunting him/her for crying. See below for an example of noncompliance at F675, demonstrating the cumulative effect of noncompliance at other tags for one resident. The facility failed to provide an environment which supported one resident's quality of life, which was the result of the cumulative effect of noncompliance, cited at Section 483.10a. Dignity and Section 483.10b2, Freedom from Discrimination, F650. Section 483.12a, Abuse. Section 483.10h, Personal Privacy, F683. Section 483.10f, Self-Determination, F661. Section 483.21b. Comprehensive, Person-Centered Care, Planning, F656, and Section 483.60c4, Menus and Nutritional Adequacy, F803. This complete disregard of the resident's quality of life caused serious harm related to her self-worth, self-esteem, and well-being. The surveyor identified a resident who was admitted 6 weeks ago and had religious beliefs which differed from the resident population in the nursing home and those of the staff. During interviews, the resident and her family reported that staff continually made derogatory remarks about the resident's culture/religion to each other within earshot of the resident or while in the room providing ADL care to the resident. This occurred during all shifts. Additionally, the resident reported that discriminatory remarks were made by housekeeping and dietary staff as well. The resident's family reported this was particularly worse on weekends when facility leadership were not in the building. The family members reported they would take turns visiting the resident on weekends to support the resident and assist with her care. When asked if this was reported to facility management, the resident said her family had reported it to the administrator on several occasions, but that nothing had changed. Interview with the administrator revealed that an in-service was planned for the future. Refer to noncompliance cited at Section 483.10a1. Dignity and Section 483.10b2, Freedom from Discrimination, F650. Section 483.12a, Abuse. F600. The resident described frequent occurrences of disregard of her personal privacy, including not covering her body completely, allowing full view of her arms, legs, and buttocks when transporting her to the shower. The surveyor observed, on one occasion, staff not pulling the privacy curtain when assisting her to dress, resulting in anyone walking in the hallway being able to view her as she was dressed. Refer to noncompliance cited at Section 483.10h, Personal Privacy, F683. On multiple occasions, the resident reported that she was assigned a male caregiver, which is against her religious belief that a person of the opposite sex cannot provide care. On these occasions, the resident would tearfully refuse to get dressed or call her family to assist her. On at least one occasion, the resident was forced to receive a shower with the assistance of a male aide, which resulted in the resident crying uncontrollably until her family arrived. Progress notes in her medical record noted this occasion as the resident becoming uncontrollable while receiving a shower. Additionally, when dressing her for the day, staff would not cover her hair, arms, and legs, and would say that her scarf was missing, only to be found when her family arrived. On interview, staff said they were unaware that this was a violation of her religion. This noncompliance resulted in the resident frequently refusing to shower or, according to family, calling her family, begging for them to come get her dressed. Refer to noncompliance cited at Section 483.10F. Self-determination, F661. The surveyor observed the meal tray setup and found it did not honor the residents' preferences identified on the meal tray card and care plan. The resident reported that this happened on most days, and even if she requested an alternative, she would be given a food item that was prohibited according to her religion, and therefore she would not eat that meal. The resident's family stated that they frequently brought food into the resident because she could not eat what was brought to her. On interview, dietary staff stated they did not have the time to prepare a special diet for this one resident and stated to the surveyor, they should have thought of that before they came to this country. Additionally, the dietary staff reported that she was not aware of the dietary requirements of this resident's religion. An interview with the consulting dietitian revealed that she was not aware that this resident had been admitted to the facility, and she agreed that the menu did not meet this resident's religious preferences. Refer to noncompliance cited at 483.60C4, menus and nutritional adequacy, F803. Review of the resident's care plans revealed that there was no identification of this resident's preferences or dietary requirements related to her religion. Refer to noncompliance cited at Section 483.21B, Comprehensive, Person-Centered Care Plan, F656. As the result of cumulative effect of the noncompliance identified, this resident suffered loss of religious and cultural identity, had ongoing feelings of extreme sadness and humiliation, and expressed a wish to die. Noncompliance, which reflects a pervasive disregard for one or more residents' quality of life, must be carefully considered for the impact to the residentess affected. For concerns which may rise to the level of immediate jeopardy, refer to Appendix Q. Tag F676. Section 483.24A, based on the comprehensive assessment of a resident and consistent with the resident's needs and choices, the facility must provide the necessary care and services to ensure that a resident's abilities in activities of daily living do not diminish unless circumstances of the individual's clinical condition demonstrate that such diminution was unavoidable. This includes the facility ensuring that Section 483.24A1, a resident is given the appropriate treatment and services to maintain or improve his or her ability to carry out the activities of daily living, including those specified in paragraph B of this section. Section 483.24B, activities of daily living. The facility must provide care and services in accordance with paragraph A for the following activities of daily living. Section 483.24B1, hygiene, bathing, dressing, grooming, and oral care. Section 483.24B2, mobility transfer and ambulation, including walking. Section 483.24B3, elimination toileting. Section 483.24B4, dining eating, including meals and snacks. Section 483.24B5, communication, including I-speech. Roman II, language. Roman III, other functional communication systems. See guidance at F677. This concludes the reading of Appendix PP. Regulation Section 483.21, tags F655 through F661.